All right, we are here in the Healthcare Rule Breaker studio and we're welcoming Elizabeth Johnson today, who is a professor at Montana State University. And we are so excited to have you here with us. So I'd love to just jump in and just let you tell your story and share with our listeners what you think has the most value in healthcare.
I want to say that any day that I can share what we're doing at Montana State University with our Bobcat nurses is a great day. And I'd like to start off with a quote that really symbolizes what we're trying to do in healthcare. And that is what Michael Murphy said, which is great design is a human right. Otherwise, what are we building and what are we building for? And who best to help contribute to great design? The nurses. And when I talk about design, I'm talking about the design of healthcare delivery systems. When you think about it, we're consumers of what we build. And as a nurse, we're right there, right at the crux of it all, seeing the patient, the system, having to navigate the policy, the legislation of how this all comes together. And that's something that we've really taken charge of here at Montana State University through the Nursing Institute of Healthcare Design, where we bring all these disciplines together to reimagine what healthcare can be and break some rules while we're at it.
I love it. So can you define for me and maybe some of our listeners, when you say healthcare design, I'm thinking, is that the care delivery model? Is that the spaces in which we work?
I would say yes and.
Okay.
It's all encompassing and it can vary day by day. So there are times where we are looking at the four walls and the roof. An example of that is creating these really cool virtual skylight schemas that can decrease delirium rates. We can also look at how we're looking at our care models, as you noted, where do we have the right people in the right time with the right resources? And many times we've all been in those hospitals where we've slipped on that part of the floor too long, or we've had to shove flushes into our pockets. Well, why is that? And why aren't we asking why more? So that's what I see design and healthcare design is asking why and.
Love that.
Okay, so number one, I am so enthralled with what does it mean to have a nurse at the center of design. So can you just share a little bit about like what is that journey? What did that journey look like for you? How did you figure out like, okay, you have this passion for healthcare and then you figured out like, okay, I have this skill set. How does that really how can we really realize the impact of this skill set on the health system?
Sure. I can say, as a mom of two, I started off really young by always my mom having to say, stop touching that, don't touch that. So I really like touching and learning and feeling the environment from a very young age. But when I came to the University of Arizona as a student, they had something that the Nursing Institute of Healthcare Design supported, which was a student challenge, a student design challenge, where they invited nurses to work with architects, engineers of different types, and you had 48 hours to create a new facility with a care operations plan and budget, which is definitely a rule break in of itself. How can we create these collision events for just creative thinking? And at that point, I was about 10 years into my nursing career and said, there's this whole part that I haven't considered before. How does the environment affect me as a nurse? And then affect my patient and how I'm setting my intention for care delivery that day. The lighting, the air quality, the furnishings, all those things I love touching as a kid. And how does this all come together? The sound, thinking about all the sounds. If you close your eyes as a nurse, I'm sure you can think of sights, smells, and sounds, right? Those three S's. So after that, I said, well, why aren't we teaching this more? Where can this go? And luckily for me, Montana State University already had a course option that brought engineers and nursing together. So from there, we've been able to be part of different design competitions, hackathons, and are now spreading this around the world with faculty-led study abroads that bring design straight to nursing. This has been including critical access hospitals, different regional healthcare systems, and empowering nurses to use that expertise, adding some new tools to their toolbox to really envision what care delivery could be.
So I'm curious, are these mostly happening, is this embedded into your curriculum at the undergraduate level or graduate level? And then the second part of the question is, we all get fired up about hackathons, right? It's a
Oh,
lot of fun and you come together, but have you seen some of these ideas be brought to life and they're sustainable?
Great questions. So we start off with the graduate program. These are nurses who are nurse practitioners. They're starting to emerge in their leadership. They're getting their DMP and saying, I'm living in this community. What can I bring as a community member to sustain my healthcare system, to maintain profitability? Here in my state of Montana, 1 in 3 hospitals are at risk of closure just this year. Used to be 1 in 4, we're at 1 in 3. So not only are we at a care delivery crisis, but we're also, I feel like, at an innovation juncture to reimagine rural healthcare delivery. So the charrettes, the hackathons that we have done have looked at that sustainability, adaptability, and maintainability of our healthcare systems in some of the most rugged areas. Some of the things that I've seen that have spun out of those hackathons, and we really like committing here, is looking at, I call it kind of design on the dime, how to heal a hospital with small intentional progress. So an example of that are those virtual skylights and windows, green walls that have shown those biophilic elements to come into a space, decrease our stress levels, actually change our brain functions to be more harmonized with our environment, to be able to focus and calm at the same time. We've also looked at shared information. How can we communicate with each other? That's part of healthcare delivery design as well. And that actually converted into this incredible grant to bring an entire regional healthcare system together, bring them together. Our undergraduates are being embedded in this type of research as well. We have pre-nursing and nursing students as well as medical students now working on different projects that include design. That includes now wearable devices in our lab, simulation, new types of computing, as well as trying different types of sustainable built materials. And we branched out now to graphic design and architecture colleagues to be part of the fun.
Okay, so I have one question that comes to mind. When I'm thinking about this, I'm thinking about, okay, I'm a nurse leader. How do I foster this design thinking? How do I foster it? Like, how can I foster it on my unit? And then how can I advocate for it?
Great question. And you said it right there, is design thinking. There is a certain level of permission that we need to give our nurses that say creativity is not only welcomed here, but it's part of the joy of nursing that I feel like has slowly eroded over time as we've become more task-based, codes and bills and all the administrative parts. The joy is why we got into this profession. The creativity in how we deliver care, it's so unique to have a profession that has care and science melded together. That's where we started, and I think that's where we can go. So to cultivate this, it's looking at identifying the solutions. I call it, what do you do if you have an idea? And establishing task force or teams of those who are like-minded, either through innovation departments, or if you are in a lower resource area, having that tie-in to academia or a larger magnet accredited system that has that evidence-based practice model within it for innovation. And starting to work on different aspects of design. So not only what do you do with an idea, but how do you protect it? How do you implement or design and iterate from it? How do you develop good stakeholdership questions? Asking the right question. We actually focus weeks on that here at Montana State to gain empathetic interviewing. You can also foster observation skill sets. And what I mean by this is something that we use from lean methods or value stream mapping, identifying areas in that patient's journey to add value, reduce wasted time. So many of my students will go to, for example, their waiting rooms at their local hospitals where they work, their pharmacies, supply management. And I can tell you, after a few minutes of striking up conversations with those different leadership teams, I see them raising their hands for committees. You're not only empowering them to think creatively in their care, but also thinking responsively on how to work with leadership to not only identify issues, but to have a solution in place, in hand, in an executive summary, and having the idea of how to help support it from a project management and implementation perspective as a nurse leader.
Okay, so I honestly, I'm blown away. I think it's just, it's one of those things like you know that these things are being done, they need to be done. And we're always looking, I'm a rule breaker by definition. It's why we started the podcast. But, just looking for ways that we can upskill nursing, and really work through the challenges that are presented with our healthcare system. And I think that design thinking piece has been a long-standing gap, right? Not only just in the way that you described, like all of the things that may fall under that umbrella, but just that skill in general and being able to empower the nurses. Because you said it best when you said like we really need to give them permission, which means we really need to empower them with the ability to know that we support the thought process, and we we'll help them work through like the challenges that will need to be overcome to implement change, because we know that changes it doesn't come easy all the time. So with that, I have one more question. What have been the ways that your students or you, when you're going into systems and you're looking at this redesign or, implementing this design thinking process, how are you overcoming those challenges and helping to really streamline and implement change in your areas?
I have to say, it starts at the diner counter. And I know that sounds weird, but something that we love doing is embedding ourselves in the community, listening to the humdrum, understanding the cadence, what those communities love. Where are the sidewalks? Where are those third places? Where do they establish community? Because at the end of the day, you don't want your hospital or clinic just to be seen as that last resort or the place that they spend for their worst day or the most crisis point of their lives. Should be a place of healing, of wellness, and encouragement themselves. And the rest follows. So we love spending our time at that diner counter. We love spending our time at the grocery stores, taking windshield assessments for any of my public health nurses out there, great allies. We also look at fostering that community, that networked community. So as I mentioned, the Nursing Institute of Healthcare Design is one. We also look at different innovation accelerators, incubators. The American Nurses Association has done a great job at that, for example, at being very approachable. And our Innovation Advisory Committee is really working to be on the pulse of what those nurses can do. So if you're a healthcare system or a nurse, these programs are for you to come in, learn in a very low risk environment, and then for your students to be able to be embedded in those communities is a plus. So I encourage healthcare systems that if these types of students or these nurses come in with a question or an idea, give them that breathing room, that observation. Let them be that flower on the wall, and let them absorb so that they convert that to mission activation.
I love what you said. It starts at the diner counter.
It really does.
And the thing is, as nurses, we know, we hear, we see, until you've been in it for a very long time and it becomes normalized, which it gets harder and harder. It's easy to see all of these things. And what I find is, and I hate saying this, I always hate saying it because I love frontline leaders and I love and respect the work that they do. But oftentimes they are the biggest barrier to implementing these things. And even listening to you say some of the ideas that have been successful and sustainable. You talk about these virtual, what did you call them?
We have virtual skylights and virtual windows now, so we can really transport you anywhere you'd like to be and have the sun feel the warmth on your face.
I believe in this stuff so much. If you've never looked online at just Google window swap, people around the country do that. It's beautiful. But my immediate thought is, where are we going to get the money for that? You even opened up with it's 1 in 3 hospitals now, and crisis is the time for innovation. It's the time that the BS barriers come down, all the reasons why we can't. And I loved what you said, yes, and I try to do that with leaders often, is don't use no, because that immediately stops the creativity. Try yes, and. But as much as I know that in my core, my immediate response to you was like, how do we do this? So what are you seeing in the leaders that embrace it, the places that have made it successful? What is it that can drive that forward besides a crisis?
It's looking at the love of community, because at the end of the day, when we're starting to look at different economic contractures in these communities, for example, in the Intermountain West, we're seeing not only a higher degree of needing to age in place, we're seeing our silver states, if you will, but we're seeing then changes in succession planning and ranching and farming. We're seeing some hurt in some economic strongholds of these communities. So how do we address now responsibly and with cultural stewardship where these needs are? You can do community health needs assessments all day, but where's the action? And so a lot of what I advocate for is you don't need sometimes those large capital projects. For example, some of these virtual windows are as low as $1,000, $750. But where's that return on investment? We love talking about risk at the leadership level. What's the risk of me doing this versus the risk of not? And that's where we go in like a big team, and we do your value stream mapping. We do your analyses, and we say, if we augment these processes, it frees up X money. And I know exactly where you should put it. You should be putting it into flooring. How about I help support you on learning how to create a really good operations budget that includes these types of renovations or rehabilitative designs. So as communities are living and breathing things, that you can be adjusting with them as well. So I think a lot of times we think of this capital cliff, if you will, when we're thinking about design. But design can be so nicely quiet and elegant and eloquent on what you're conveying to the community. In fact, one patient said it best, and I hold this in my heart. There was a dent on a wall in a hospital. And you know what he put on his satisfaction survey? He said, the whole time I've been here, that dent has too. If you can't fix a dent on the wall, how can you fix me? And I think every leader needs to think about design differently and more critically, because that is the perception of your staff, your patients who are coming in, and ultimately the community. Having a strong, assertive stance in how you're approaching design and including voices in it will only give back to you through investment on the future.
Okay, so this conversation has definitely had a profound impact on me. I think there's a couple of things that I'm going to walk away with whenever I go and talk to other leaders and really strategize with them on how they can. I always have tried to take Crystal's advice on the yes and, but you also said why and, which I thought was very impactful as well. I think there's two parts to that conversation. Like, yes, you can say yes, and then we also need to ask why. And continue to have that conversation and leave that open. So I think those two things are my walk away for today. So I am so grateful for you coming on the Healthcare Rule Breakers. When I saw you on LinkedIn and the work that you were doing and talking about, I was so excited. I was like, oh my gosh, this is so incredible. We need to be part of, I wanted to be part of your story, right? Like hear more about it and understand it so that it can be shared and propelled. And so with that being said, I know you have a rule that we need to break. And on the Healthcare Rule Breakers, we would like to know if you, Dr. Johnson, are breaking any rule in healthcare. What rule are you breaking?
I would have to say that nurses should be policy holders and legislators, and that should be a requirement in every state that you must have a nurse in your legislative body, whatever level it is, because not only are we rule breakers, but we can be rule makers that can help advance healthcare no matter where we are. When we've shown here in Montana, there's big innovation in Big Sky country, and some of the best ideas come from the smallest towns. So let's create these types of rules together.
All right, I love it. Okay, so if anyone wanted to get in contact with you, maybe just for conversation or for services, what does that look like for you? Where's the best place for them to connect?
You can find me on LinkedIn, or you can email me, elizabeth.johnson37@montana.edu.
All right. Thank you so much for the gift of your time and your knowledge. I mean, you airdropped it today, so
Yes.
I'm so
Thanks for having me. See you next time.